We're good to go.
Good evening, everyone. This is Dr. Manvitha, Consultant Emergency Medicine at Yashoda Hospitals, Hitec City. Welcome to the online webinar session conducted on every Friday by the Yashoda Department of Yashoda Hospital, Hyderabad. Today we have Dr. Rajas, Consultant and HOD, Department of Emergency Medicine at Victor Hospital, Goa, to discuss about the approach to chest pain in ED. Welcome, sir.
Thank you. Thank you for the kind introduction.
Please start.
So, welcome everyone. Today I'm going to talk about an approach to chest pain from an ED perspective. Obviously, when we start out in medicine, we have various approaches towards a symptom. I think let's just the idea of this talk is to just sort of focus it towards an ED sort of perspective. What are the things to look out for? What are the things you don't want to miss? So let's get started. So just a bit about my background. I've done my MEM, completed in 2015, and then I went on to do my MRChem and subsequently my FRChem as well. Worked for a bit in the UK. So coming to the case, we've got a 51-year-old who's basically coming in with some chest pain for the last 2 hours. Says he's just woken up from his sleep, describes the pain as absternal, squeezing, sharp. In terms of his background, he's a diabetic. He's got a history of coronary artery disease with a previous history of an MI. He also has reflux disease as well, and says that this feels like a mix of reflux and my last heart attack. So this is a bit of a conundrum because it can be anything. So basically, a large part of the general population will experience chest pain during their lives, and a lot of them will come to the emergency department because obviously people, are quite aware that any form of chest pain, is a cardiac event until proven otherwise. So they will end up in the emergency department, and you will have to decide how you want to approach this patient. So it is obviously going to be a diagnostic as well as a therapeutic challenge. And a few of the diagnoses can end up being very critical diagnoses. It is the number one reason for ED visits in patients about more than 65-year-olds. Sometimes you might have an atypical chest pain, which is the typical presentation, especially in females, elderly, and diabetics who have a certain degree of autonomic neuropathy. So we will go through some definitions, that of chest pain, acute coronary syndrome, unstable angina, and STEMI, non-ST segment elevation ACS, and obviously ST elevation MI. So the main learning outcomes or objectives for this talk is going to be just reviewing the epidemiology and also the various causes of chest pain that you might encounter in the emergency department. So at the end of the talk, we should be able to outline a very standardized and systematic approach to patients with chest pain. Also, we can review some of the potential diagnostic tests which can aid in evaluation and sort of narrow down the symptomatology towards the diagnosis in patients coming with chest pain. We can also review the risk stratification tools for acute coronary syndrome as well. So what is acute chest pain? Typically, it's less than 24 hours, which is causing the patient to seek prompt medical attention. The location is generally on the anterior thorax, and it is a sensation which is causing a bit of distress to the patient. So this should be enough that the patient will come to the emergency department. So it can represent both the somatic as well as the visceral etiologies. Somatic is a very localized pain. So it is precisely located and generally experienced as a very sharp pain. Whereas a visceral sort of sensation is more difficult to describe and not able to sort of localize very easily and can be misinterpreted. So just coming to when you see a patient in the emergency department with chest pain, what are your priorities? Obviously, you want to triage them and stabilize them. One of the questions that always crosses your mind would be, should I intervene immediately? Does this patient need to be, given some prompt medical management? What are the life-threatening possibilities in these patients? How does the patient look? What is the ECG like? What are the patient's vital signs? So these are all questions which are going to be going through your mind whenever you see a patient, especially a slightly sicker patient, maybe coming with chest pain with the emergency department. Now, talking about the approach, uh, anybody coming with chest pain needs to be triaged promptly. These patients obviously cannot wait. They need an urgent assessment, whether by the nurse who will do the triage or and seen soon enough by a doctor as well. So you can perform a safety net, which is putting the patient, especially the slightly unwell patients or having severe chest pain, you put them in a treatment bed, apply monitoring, put in a cannula, administer some oxygen, and get an urgent ECG. Your approach will always be the ACLS way to assess a patient, which is ABCD, airway, breathing, circulation, visibility, exposure. So always follow your ABCDs whenever you see a patient, and then go on to perform a secondary survey. So a very simple algorithm can be, just doing an assessment, and on your ABCD assessment, you can decide whether the patient uh, will need an emergent procedure, for example, a needle thoracostomy in a case of tension pneumothorax, or um, you can proceed towards some diagnostic tests and sort of come towards these diagnoses, which are critical diagnoses. There's a bunch of differential diagnoses that are going to be part of the chest pain syndrome. However, these are the ones that you need to be aware of. These are critical diagnoses, and if missed, can be catastrophic. So, in terms of the critical diagnosis, we have obviously cardiac events, cardiac tamponade, aortic dissection, which is a very important diagnosis, pulmonary embolus, and obviously esophageal rupture as well. Some of the emergent diagnoses which can come with chest pain are unstable angina, coronary spasm, mediastinitis, cholecystitis, pancreatitis can also sort of present with slightly lower chest pain as well. Whereas these are all your non-emergent diagnoses, which can be sort of deferred in terms of management. But priority-wise, always think of your critical diagnosis, and the patient will also need treatment for emergent diagnosis as well. So in terms of the history, as you might have learned in medical college or after, obviously there is a way to take the history and a way to describe the various characteristics of the pain. And also you can think of certain p-test probability modifiers as well. Some of the historical factors which increase the likelihood of things like an acute MI are radiation to the right arm or shoulder with a likelihood ratio of 4.7. Radiation to both arms is also quite high. associated with exertion, radiation to left arm, associated with sweating, associated with nausea, vomiting. So these are all going to be red flags whenever you hear the patient, describe the pain, saying that it's going to my right arm or shoulder, or it's going to my left arm, or it's worsening with exertion. These are all going to go towards a cardiac cause. And some are factors which decrease the likelihood of an acute MI. Things like, it's a sharp pain, worse with respiration, which is described as a pleuritic pain. Sometimes a positional pain on movement, which is more likely going to be a musculoskeletal pain, which is reproducible with palpation, and generally like an inframammary location as well, and not associated with exertion. So these are important because these can be, sort of adjuncts towards uh, sort of coming to another diagnosis besides just a cardiac diagnosis. Okay. In terms of risk factors for acute coronary syndromes, obviously this is something that we deal with, on a daily basis. So these are all questions that we ask patients in terms of their previous history or just general demographics or past family history of coronary artery disease. So these are all factors which put the patient at a higher risk of an acute coronary syndrome. Obviously, things like cigarette use, elevated cholesterol, which is a very, very important finding in most patients in India. A large population, will have very high cholesterol, and that will go untreated for many, many years before patients actually, do something about it. So that is a primary prevention which we can always sort of focus on. Or obviously, lifestyle choices as well. Having sedentary lifestyle, losing weight. These are all important causes, important factors towards cardiac event. Some of the risk factors for pulmonary embolism, as you might be aware of, is obviously immobilization, prolonged surgery, prior thrombi, deep vein thrombi, pregnancy, which is a hypercoagulable state, of cancer, which is a hypercoagulable state, pelvic or lower extremity trauma, which renders the patient, immobilized as well for a prolonged period. In oral contraceptives with cigarette smoking is another important cause of PEs with in generally younger female populations. So it's really important to ask about oral contraception and cigarette smoking, which puts them at a higher risk of developing a PE. And obviously, genetic conditions which sort of which are sort of procoagulant states, like protein CNS deficiency, factor V Leiden. All these are conditions which can promote hypercoagulable states in patients. So coming towards pneumothorax. So generally, prior pneumothorax is a risk factor itself. Valsalva's maneuver rarely can cause chronic lung disease, which can cause, secondary pneumothorax. Cigarette use with patient at risk as well. Coming towards aortic dissection, some of the risk factors are hypertension, congenital disease of the aortic or aorta or the aortic valve, myocarditis or pericarditis, cigarette use, atherosclerosis. So aortic dissection is a devastating condition, and it can be absolutely catastrophic if not diagnosed in time and operated upon. So you need to have a very high risk of very high suspicion for aortic dissection in certain patients which have these risk factors. So in terms of workup, obviously you want to do a good physical examination, look at the patient, look at all the vital signs, get a blood pressure, heart rate, oxygen saturations, respiratory rate, temperature, and then try and sort of apply all the findings towards your clinical examination as well. Do a detailed cardiovascular examination, especially in patients coming with cardiac sounding chest pain. So as part of the secondary survey, you can proceed towards, neurological and extremity examinations which might be abnormal in the case of an aortic dissection. Ancillary studies like ECG and chest X-ray do facilitate diagnosis and basically expedites total treatment time, especially for PCIs and thrombolytic therapy, especially in acute ST elevation MIs. So these can be supported by things like ABT or a CTPA, which can aid in diagnosis of acute PEs or any hypoxic state, um, such as PE or pneumonia, which can be the reason the patient has come to the emergency department. In a chest X-ray, you can look for things like a widened mediastinum, a mediastinal shift for a pneumothorax, check for effusion, check for the increased cardiac silhouette, which might be indicative of pericarditis with a tamponade or a pneumomediastinum. Sometimes you can see a very thin rim of air around the mediastinum, especially on the left heart border, which is suggestive of a esophageal rupture, in which case you need to proceed for a CT. So doing those portable chest X-rays can be quite useful at times. So these are just some of the ECG changes that you want to look out for in a classic MI or a subendocardial infarction for a non-STEMI or an unstable angina, and some ECG changes for pericarditis as well, which include diffuse ST segment elevation and PR segment depression, which I'm sure everyone's aware of. So I'll just go through some ECGs here. As you can see, this is a classic sort of anterior wall MI. Here you can see some reciprocal changes in inferior leads, and you can see sort of anterior and sort of lateral changes of ST elevation. In this case, you can see clearly inferior wall MI, where you can see the ST segment elevation in 2, 3, and AVS. There are some reciprocal changes as well that you can observe. So in this case here, you can see some changes in leads V1, V2, and V3. And there are some ST elevations in V5, V6, 1, 3, sorry, 2. So in this case, especially when you see a kind of a sort of horizontal ST depression, especially in leads V1, V2, and V3, you would want to check for posterior leads, V7, V8, and V9, which upon doing so will show evidence of a posterior myocardial infarction, which can be easily missed. And in the case of an inferior wall MI, it's quite frequently associated with a right ventricular infarction as well. So it's very important to do the right-sided leads. As you can see here, the V4R is confirming ST segment elevation. So coming to myocardial infarction, it's quite a severe discomfort, and it can be rapid in onset. And some people have described pressure more than pain, and it's generally not relieved with NTG. They can be associated sweating, nausea, vomiting, breathlessness, as we discussed before. It can be precipitated by emotional stress or exertion. We see younger and younger patients now, especially in India, coming with acute MIs. But generally, historically, age more than 40 years with risk factors, male sex, increase the possibility. You'll find that the blood pressure is generally elevated unless the patient has completely gone into a cardiogenic shock state, in which case it can be very, very catastrophic unless there are temporizing measures like, you know, putting an IABP in the cath lab or having some bridging therapies like ECMO. Heart rate can be increased, but also you can see some bradycardia as well. Here's where the beta blockers might come in. So patients can be very diaphoretic and show peripheral perfusion when they go into pulmonary edema and heart failure and cardiogenic shock, because this is a very malignant course in an acute MI. So what are the diagnostic tests? Obviously, we've talked about ECGs. Cardiac markers are very helpful, but they can be normal in a very acute MI. Hence, it's very important when there is a diagnostic uncertainty to do serial proponents. Sometimes you can get atypical chest pain, as we have alluded to before. Some patients may describe it as an indigestion, a burning sensation, unable to describe. Sometimes patients might even present as a stroke or a collapse. So you need to have a high index of suspicion in patients who have risk factors or have presented in with these sort of symptoms, where they have just come as a collapse. Elderly images come with generalized weakness, heart failure, or chest tightness. Almost 25% of MIs which are non-fatal go unrecognized as silent MIs, which are only later sort of established on an echo or on an ECG, which shows, you know, Q waves or chronic changes. Sometimes the pain might have even resolved by the time of evaluation. For example, if there was a coronary artery spasm. So this is the universal classification of MIs. Type 1 is the MI that we are all used to, which is caused by atherosclerotic plaque rupture, platelet emboli, causing myocyte necrosis. Type 2 MIs, you might have heard, they are due to ischemic imbalance. Myocardial injury can occur when a condition other than coronary artery disease contributes towards that mismatch between oxygen supply or demand. Things like coronary and endothelial dysfunction, coronary artery spasm, tachycardias, bradyarrhythmias, anemia, respiratory failure, shock states, hypotension, or hypertension with or without LVH. So type 3 MI is when MI resulting in death happens, but biomarker values are unavailable. So this is more of an academic sort of definition. And type 4A is related to PCI, type 4B is related to stent thrombosis. And these have their own specific criteria, but they're outside of the purview of our talk, which is more confined towards emergency medicine. Let's talk about unstable angina. Again, when we talk about the history, this is a change in the pre-existing angina pattern with a more severe or prolonged or a frequent pain. And these episodes can last more than 10 minutes, occurring at rest, and occurring with minimal exertion. So whenever the patient has new symptoms which are eclipsing his usual angina symptoms. These are red flags and can suggest an impending thrombus. The responses to NTG and rest are unpredictable. So this change in pattern is important to engaging the risk for an acute MI. So they can have increasing dyspnea on exertion. It's not clearly related to precipitating factors. And again, the risk factors are quite similar. The diagnostic test, again, you may not see any ECG changes or enzyme changes. So if you see an ECG which looks like the old one, don't be fooled that there is no acute event going on. You have to go by the history, and also you would want to do some bioenzyme tests as well, like troponin, which may come normal. However, in the context of a pre-existing coronary artery disease and classic angina, you have to have a high index of suspicion that this is now unstable. In variant angina, which is Prince metals, you can have episodic pain, at rest, severe, and you might see some prominent ST segment elevation as well. So some of the atypical presentations are being pain-free, hence a full history is essential. And about 15% of the patients do go on to have an acute MI who've been hospitalized for unstable angina. They can respond to NTG. So in terms of cardiac pain, it's really important to do a good risk stratification. Some of the tools that we have are these validated scores. So this is the TIMI risk score for non-STEMI. So it's a prospectively studied and validated tool, but it's got some limitations where you have to have positive cardiac markers as part of the guidelines, and even low risk patients found to have a risk of almost 4.5%. So GRAY-SCO is another multi-center prospectively studied tool, which estimates basically it's a prognosticator of in-hospital and 6-month mortality. These are the categories which are considered as part of the GRAY-SCO, right from age, heart rate, creatinine, associated cardiac arrest. So generally, it's to be used with known ACS, and obviously there's a lot of factors to be calculated. Generally, scores more than 140 are considered as very high risk. Then you have the heart score as well, which evaluates for major cardiac event risk in the next 6 weeks. So here you are considering factors like history, ECG, age, risk factors, and troponin. There are 3 tiers: low risk, moderate risk, and high risk, depending on the scores. Another score is the ADAPT score, which basically uses 3 criteria, which is normal troponin at 0 hours and 2 hours, ECG without ischemic changes, and a TIMI score of 0. So if you have all of these, then the risk is very, very low. So coming to cardiac pain, again, history, which is a very good pretest probability modifier. Physical exam, again, you may or may not find it useful. Diagnostic testing, again, it is driven by, the history as to what the history points towards. And again, know your risk stratification tools and always talk to your on-site cardiology doctors. So here we are seeing some patients who have hypermobility, Marfan syndrome. This is a classification of aortic dissection. It has two classifications, which is the Bakey and Stanford. Just to simplify things, we will just stick to the Stanford classification, which is a much more a simpler classification, which is just divided into type A and type B. So if there is a dissection before the left subclavian artery, then it's a type A. If the dissection is distal to the left subclavian, then it's a type B. Now, aortic dissection, it is a extremely tearing chest pain, and which is maximal at the beginning. It tends to radiate towards the interscapular area or to the abdomen. It can present with neurological complications like stroke, peripheral neuropathy, or paresis, as it can basically obstruct the blood vessels as a result of the dissection. It can even cause paraplegia, abdominal, and extremity ischemia. The ratio is skewed towards males, 3:1. And generally, the patients are hypertensive. So managing hypertension would be a good primary prevention. Marfan syndrome and congenital bicuspid aortic valves have obviously an increased incidence. So this is a bit of a paradox. When you see an aortic dissection, they have a very elevated blood pressure, but there might be areas or extremities which are very poorly perfused, especially when you don't have a pulse in the leg. That is a extreme red flag in the context of chest pain. They do sort of dissect proximally to cause aortic insufficiency and may even cause tamponade and cause coronary occlusions as well, causing an ECG to show ST elevation MI. Very rarely you might see a friction rub or a new murmur. So it's really important to do a good examination and have a high index of suspicion, and making sure the patient has an urgent aortic CT aortogram to confirm the diagnosis. So obviously now in the emergency department, we are very adept with the ultrasound to do the point of care ultrasound. Here you can see the suprasternal view, which shows a dissection flap in the first image. In the second image, you can see a dilated aortic root. Generally, more than 4.5 centimeters is what you would look for on a parasternal long axis view. You can see some hemopericardium here as well in the context of symptoms suggesting an aortic dissection. If you see pericardial fluid, it is hemopericardium. So a transthoracic focus is 75% diagnostic for type A and 40% for descending, which is type B. It can identify these complications like aortic regurg or reaching wall abnormalities or cardiac tamponade that we've just alluded to. Here is a CT which is showing a dissection flap there as well. So you can see the false lumen here, and this is the true lumen. So diagnostic tests, again, the ECG changes can be non-specific. The chest film may show an abnormal aortic silhouette. But the main thing you would want to do is a CT aortogram, which would be the most useful in achieving the diagnosis in most centers. So atypical findings, again, very similar to the previous syndromes. They can be, it's rare for the patient to be pain-free because it is such a painful condition. Again, we talked about the neurological complications. So they might just come with a stroke. And again, it's an MI mimic if it dissects into the pulmonary artery. Generally, ascending aortic aneurysms or the type A dissections are approached surgically, while descending can be stabilized medically. So coming to another case scenario, 63-year-old woman with stage 4 lymphoma calls her ambulance for acute shortness of breath. Generally, she's quite mobile and does not have any difficulty breathing. She's taking hormone replacement therapy, and on the day of the admission, she suddenly develops shortness of breath and a new pleuritic chest. She does not improve with nebulizer treatment on the way to the hospital. In the emergency department, her pulse is 115, so she's tachycardic. She's very tachypneic at 36 per minute. She's slightly febrile at 38.3. She's hypoxic on room at 88. But on exam, her lungs are clear and extremities are normal. Her chest X-ray shows very mild right-sided atelectasis, whereas an ABG showing some hypoxia, CO2 of 7.1 on room. So what is the patient's pretest probability for having a pulmonary embolism? And what diagnostic method would you use to confirm this? So we can use the Wells criteria, which is a good sort of pretest probability modifier. And in patients who are less than 50 with some chest pain, you could potentially use the PERC score as well. This is the classic S1Q3 T3 pattern ECG, but it's rarely seen in a real context. You can see evidence of right heart strain as well with right ventricular hypertrophy. And a dominant sort of S wave in the 5 and 6. The pulmonary embolism, it's generally lateral pleuritic chest pain, whereas the central pain would be more consistent with a massive embolus. It can be abrupt and maximal pain may be at the beginning, but it also might be episodic as well. Dyspnea apprehension is prominent with cough in 50% of the cases. You may not always see hemoptysis. And angina like pain might occur in about 5% of patients. So what are the risk factors that you would see? Again, we went through some of the risk factors earlier, where we talked about prolonged immobilization, hormone therapy, cancer, pregnancy, surgery, limb trauma. So patients are very anxious and they tend to be breathless with high respiratory rates. You can see tachycardia, which is quite frequent in these patients. Very rarely, you can even have some fever. In pulmonary embolism, generally you will see a viral A gradient. Wellscore and D-dimer testing are very useful. We can also do a point of care ultrasound. Chest film is normally used to rule out any other cause or any other lung pathology like pneumonia or a pneumothorax, in which case you can proceed for a CTPA scan. If your suspicion is high on your clinical examination and diagnostic tests. In some patients, you might want to do a VQ scan. CTPA scan requires contrast. Some patients can be allergic to contrast. Hence, they can have a lung perfusion scan. It can rule out if truly negative. But the test of choice is always going to be a CTPA scan. Now coming to focus. So I'm just showing you this echo. This is what a normal parasternal short axis view would look like, where the right ventricle is smaller than the left ventricle. And the left ventricle clearly sort of indents on the right ventricle with the septum. This is called the O sign of the left ventricle. Now, in a massive PE, where there is a pulmonary arterial obstruction, you will have a back pressure which is transferred into the right ventricle and the right atrium. Here you can see a septal flattening, and you can see the right ventricle clearly indenting on the left ventricle. You can see the septum here, which is moving towards the left ventricle, making it look like a D. So this is called the left ventricular D sign on a parasternal short axis view, which is very indicative of right ventricular strain and dilation and possibility of a massive PE. So again, here you can see this is McConnell's sign, where the lateral wall of the right ventricle is pretty much akinetic, and the apex of the right ventricle is hyperdynamic. Here you can see the inferior vena cava. Generally, we can see a respiratory variation. However, in this case, you can clearly see that the IVC looks plethoric. It's dilated, it's full, it's got a higher pressure, which is transferred from the right atrium. So in pulmonary embolism, patients can have dyspnea with or without bronchospasm. You can have a mortality rate of about 10%. As we know, generally, the emboli are usually from the lower extremities above knee, prostate or pelvis, venous plexus, or sometimes even the right side of the heart, if there is thrombus present. So coming to the next case. So you have a 47-year-old female pedestrian brought by an ambulance to the emergency department after being struck by a car, and now is complaining of shortness of breath and chest pain. So this is the ECG, this is the X-ray that you've noticed. But prior to this, you would have done a clinical examination. This clearly shows a massive pneumothorax. And in a clinical context, can even the attention pneumothorax. So in attention pneumothorax, the chest trauma is quite a common cause. Hence, it is very important to do a good ABCD examination and perform timely interventions in the event of any obvious finding. So you will have very reduced breath sounds and increased resonance on your assessment, especially on the primary survey. You can see elevated pressure in the neck veins in tension pneumothorax because this is so the pneumothorax is pushing the lung so much that it is causing an obstruction in the heart, an obstructive shock. And that pressure from the pneumothorax is causing an elevated pressure in the neck veins. This is an absolute emergency and needs needle decompression promptly. This is generally done in the safe triangle in the mid-axillary region, where you would also put the tube, a chest drain. So just coming towards an overview of what we have done in terms of a structured approach. It's very important to do an initial evaluation, apply cardiac monitoring, intravenous access or oxygen therapy based on the patient's clinical appearance or needs. The differential diagnosis again is based on your history, your physical examination, and any specific tests that you might be performing based on what you expect to find, whether it's aortic dissection, pulmonary embolism, tension pneumothorax, esophageal rupture, or pericarditis, and providing the necessary treatment. So just coming to a summary of what we have done. We did talk about the epidemiology and the differential diagnosis of chest pain. We talked about a structured approach towards chest pain. We talked about what are the critical things to look out for that we don't want to miss when doing an assessment of a patient with chest pain. And we also talked about some of those risk stratification tools as well for ACS as well. So I'm happy to take some questions. If that's okay.
It looks like we don't have any questions, sir.
Okay.
Thank you so much for the wonderful session.
It's a pleasure. Thank you for the opportunity to do the talk. It was my pleasure.
Thank you.
Okay, thank you.